Hello everyone. Now we will start today's lunch symposium. At first, I still need to thank for Boston. They give us this opportunity to share the experience about the drug-eluting stent Eluvia. I think today's topics will focus on the drug-eluting stent Eluvia. And because initially we have three speakers today, but Dr. Ida is still on the demo side, so we will a little bit adjust our speakers order. So first we will arrange China's doctor as the first speaker, and our native speaker Shu Han will as the second speaker, and finally Dr. Ida is the final speaker. So today, Dr. Xiping Wu and I will moderate today's lunch symposium. And we also have several panelists, and we have the Dr. Lin Yue Hong, Dr. Ji Naiyu, Dr. Hong Junsheng, Dr. Chen Bo-wei, and Dr. Liang Huaiwen, Dr. Xu Rende, Dr. Cai Minlong, and Dr. Zhang Jiaxiu. So I think I will start to introduce the first speaker. The first speaker is from China, and because some personal issue, he just can record the video. So today he will show his speeches the video. So let me introduce the first speaker. I think Dr. Zhong Hao is an associate chief physician in the Department of the Vascular Surgeon at the Fushan Hospital, Fudan University. He has several experience in the PAD field. He also received several awards and published several literature in the peripheral field. So I think today his topic is patient selection and the treatment strategy for the Eluvia stent. So I think we can start the video.
这个题目呢，当时主要是考虑到，因为现在那个 DES 上来以后呢，有很多的医生都在问，我们现在已经有了 DCB 加 BMS 的模式了，是不是还有必要有这个 DES？ 所以呢，就设计了这么一个题目。那么主要呢就是比较一下那个两种模式的差别。那么因为现在我们的 DES 也就是 Eluvia 在中国能够用，所以今天呢就是讲 DES 的话呢，我主要是针对 Eluvia， 因为还有其他的所谓的 DES。那么当时觉得做这个题目其实不是太难，但是做着呢就觉得问题一点点都出来了，和我当时的有很多的当时都没想到，所以呢今天呢把这些问题都抛出来，我也希望在后面的讨论时呢跟大家一起探讨。那么关于这个两种模式呢，现在大家问的问题就比较多的就是说有了 DES 以后我们是不是管腔准备可以简化了，也就是现在经常提到的所谓的 EZ 模式。那么第一部分呢，我想讲的就是那个两种治疗模式在血管准备上面到底有什么差异这是一个。另外一个就是说，有了这个 DCB 加上 BMS 的话，那个到底有没有需要有 DES 这样一个治疗模式？那么这个呢，其实是第二部分，也就是两者之间在疗效上面到底有没有差异。那么谈这个疗效的差异的话呢，我觉得首先要从循证的依据上去探讨。但是循证依据呢，它其实往往那个数据都反映的是个现象。那么我们还要从那个事物的本质上面来看。那么其实这两种模式其实都包含了两大因素那么元素就是一个是载药的一个技术，第二个呢就是支架的平台。那么今天呢这个就是我要讲的两大部分。那么先讲一下到底这个是不是就是我们的那个血管准备可以简化了。那么对于这个血管准备的一个必要性，其实今天早上我们在 iEndo 上面也有很激烈的一个讨论那么我个人感觉其实 EZ 模式并不是因为 DES 来了以后才出现，其实 EZ 模式本身就一直存在的，只不过现在因为我们对血管准备很重视了忽略了这么一个 EZ 模式。那么在我的心目当中呢，我觉得并不是所有的病变都需要做充分的管腔准备的。所以今年呢，在第一期的执行上观里面，我就画了这么两个圈，就是我们可以把我们的那个骨骼端的病变就是分成两大类，一类就是 planned stent也就是说你计划内的支架，就是说你看上去这个病变一上手你就觉得需要做支架治疗的。那么其实呢，这部分的病变 在我看来就包括了肠断病变，弥漫性的严重钙化，还有一个呢，我叫它的不稳定管腔。不稳定管腔就像刚才我们陈斌老师提到的就是你这个管腔里面有一些陈旧性的血栓负荷不多不少的或者那个斑块的性质就是比较松脆充分的一个前扩容易造成远端栓塞的这种呢，我们往往就会先做一个支架治疗，然后再做充分的后扩。还有一个就是全程的内膜下开通的，其实这类病变其实你上手其实就觉得是计划内的支架那个过度的管腔准备其实是没有必要的那么真正需要做那个充分的管腔准备的是第一类病变，就是支架仅仅是作为一个补救性措施的，那么它可以包括一个短病变有些短病变就是说它是个偏进性的又是比较散在的，那么这个呢我们可以用 DA 就是那个减容的硬化性减容的方法去治疗，然后再加 DCB。那么或者是一个虽然是病变比较长，但是里面有比较多的血栓负荷的，我们可以用 PMT 把里面的血栓清除了以后把它转化为短病变进行治疗。还有就是跨关节的病变就不适合做支架治疗。其实我们充分的管腔准备主要是针对一类病变的那么对于那个二类病变的话呢，就是我觉得还是有必要做充分的前扩但是呢刚才也讲到了，就充分的前扩你会发生什么问题呢？就是刚才就比较担心的有可能会发生远端的栓塞那么这种情况呢，其实我们呢用怎么去解决呢？因为我们以前如果你做 DCB 治疗要做那个补救支架的话，我们是先上 DCB 再做支架的。但是如果我们碰到了这种所谓的不稳定管腔了，里面有或多或少的那个血栓负荷的，或者就是那种斑块比较松脆的，那么我们呢往往会先上支架那么上 DCB 的话呢，其实因为 DCB 是普适性的，你放了一个支架还是可以用 DCB 的但是呢如果是这样的一种模式的话，先上支架再上 DCB 的话，会碰到什么问题呢？一个如果是等长的支架和球囊的话，你经常会发现那个球囊会比那个支架短一点，那么这样的话呢，它两头就涂不到药那么或者是涂药不充分以后会有个隐患。那么如果你这个 DCB 又出头的话呢，虽然说是支架的两端你这个有时候这上面也可以出头，支架的两端能够涂到药的话，但是你会发现什么问题？像这么一个支架放好以后 ，DCB 出头了，大家可以看到远端出现一个夹层。那么还有一个问题就是支架放好以后再用 DCB 的话它有一个门板效应，就是你支架后面没有涂到药，到底有没有影响现在还不知道。但是也有一种观点，就是说你支架放好再涂 DCB 的话因为支架的切割会使得这个药物能够更好的弥散效果反而更好。那么这个呢现在都没有定论。但是呢能够解决刚才我们讲的不稳定管腔的一个最好的办法，其实我觉得就是 DES 那么在年终的时候呢，那个播客给我出了个题目叫那个血管准备好以后最后一棒交给谁当时呢我给的答案是对于一类病变你如果管腔准备好以后，你就做一个评估，评估以后你觉得可以走那个 leave nothing behind 的话，就上 DCB。你如果觉得需要做补救型支架的话，你可以用 DES 那么对于二类病变的话因为这个是计划内的支架如果费用不是太宽裕的话，那就单纯的那个 BMS。如果费用还是有宽裕的话，我们可以用 DES 去治疗。那么当时呢，我觉得这样的话呢，基本上把思路都理得比较顺了。但是后来呢，我仔细想了一下呢，其实里面还是有些细节的问题没有讲清楚。当时我记得在线上的时候，贾欣教授就问了我对于一类病变如果你做了那个评估了以后，发现只是要在局部做一个支架治疗的话，你到底是怎么那么这个时候我觉得的确是的，我因为不可能说 DCB 全身的覆盖以后再在局部用一个 DES 那个时候的话还是需要 DCB 加一个局部的一个支架。所以我刚才给出来的这么一个答案的话，大家可以发现我把 DCB 加 BMS 这个模式完全给剔除了。那么从这个角度来看，其实并不是很合理的。所以接下来呢就进入到就是说 DCB 和 BMS 这个模式在 DES 的存在下面，它是不是还是有它的必要性？那么首先呢，我想就是说来比较一下这两者之间到底疗效上面会不会有什么差异。那么首先讲循证依据。我们今天早上呢在 Angle 上面呢也跟大家讨论，其实到目前为止我们可能还缺乏的一个完全的两种模式的头对头的一个研究。那么我们现在手头上面能够有到的一个依据呢，就证据呢，就是这么一篇文章，早上的时候呢，其实两位教授也谈到了从那个作者上面来看，应该是个莱比锡牵头的做的一个研究。那么它呢其实是186例的病人，是个多中心的。然后呢剔除以后呢一共是150个，它就分成两组那么按照那个长度呢它在对位。那么一组的话呢就是 DCB加上那个补救支架另外一组呢就是 DES。那么 DES 的话呢 它这里选用的是 Silver PTX 那么里面有很多内容，我就把主要的那个先提出来看一下。那么管腔准备以后，大家会发现两组里面从夹层这个角度去判断的话，其实 DCB 这一组的结果要差，要比那个 DS 要差。那个 C 型和 D 型的夹层的那个数字明显的要比 DS 多，所以这个 P 值是小于 0.001 的。那么在 DCB 这一组里面呢，大家可以看到补救性支架其实并不是很高，只占到了 25.3%。那么这两组它的结果到底什么样呢？就是从总体上面来看，两者之间并没有什么差异。它随访了3年，3年的话，其实第3年的数字是比较少，病例数比较少。那么里面有些亚组我今天下午还仔细的看了一下，是比较奇怪的那个如果你从那个狭窄病变来讲呢，其实 DS 要比那个 DCB 这一组要好，但是闭塞性病变呢又是没有差异的。短病变是没有差异的，长病变还是有差异的，但是这个差异呢也并不是非常大。那么这样的话呢，就是比我们的预期上面来看，好像是有差别的，因为我们觉得好像 DS 的话应该要比 DCB 加上那个 BMS 要好。那么到底为什么怎样呢？上午我也跟2位教授探讨。那么里面的原因肯定有很多，一个是它是一个 pilot study， 是个初步研究，其实病例数不是很多，随访率还是比较高的。另外呢，就是到了后面的随访的话，其实病例数都比较少。另外一个就是它的选用的支架是 Silver PTX， 那么这款支架呢，大家也知道，它其实我觉得并不是一个纯粹意义上面的 DS， 所以呢，做一个小小的那个小结吧。首先从那个血管准备的一个方面来讲其实对于计划内的支架植入它本身其实就不需要太过度的血管准备，当然这个不包括充分解剖所以呢在这个地方呢，其实DS 的出现它其实并不是说带来一个那个 EZ 模式，其实 EZ 模式本身来说就是存在的。那么对于不稳定管腔的处理我个人觉得DS 相对于 DCB 加 BMS 的模式更加有效和安全。所以今天我在挑那个查房病例的时候我是特意的那个挑了那个郭主任的那个 DS， 因为当时我在看的时候我也担心这个管腔里面是不是会有一些血栓如果真的是有的话呢，我个人的感觉就是直接上 DS然后再做后扩，这样的话呢要比 DCB 加 BMS 的模式更加好。那么对于那个2个模式之间到底有没有差别的话，我觉得从载药技术的角度来说虽然现在我们还没有非常那个绝对的头对头的一个循证依据，但是从那个它的构成来讲，我觉得 DS 相对 DCB 加 BMS 的模式的优势是可以预见的。但是呢，回到支架平台上面来讲，如果是一个跨膝的病变，或者是近膝关节这个地方又有很明显的扭曲的形态，或者是很小口径的血管的话这些对于那个支架平台有更加大的挑战的场景的话 ，DCB 加 BMS 的模式仍然是优先考虑的选项。那么关于那个2个模式之间的比较呢，就跟大家介绍到这里，谢谢大家。出这个题目呢
because we have a panel discussion later, so now we will move to the next speaker.
Okay, I'm Dr. Xu Pingwu from Hsinchu Makai Memorial Hospital, and I'm honored to introduce the next speakers. The next speaker, as we all know, Dr. Donna Lin. I will give the brief introduction. Donna Lin, Dr. Donna Lin graduated from National Yangming University and then complete her cardiology resident and fellow training in National Taiwan University Hospital. And now she is a cardiologist served in Xinguang Wuhuoshi Hospital. And now she will give us a very informative talk about Eluvia stents. The topic would be from challenges to solutions, Eluvia case highlights. Donna Lin, please.
Thank you, Dr. Wu, for the very kind introduction. I am Donna Lin from Xinguang Hospital in Taipei. And today it is my great pleasure to share 2 cases in which I used Eluvia. These are my disclosures. I think everyone doing peripheral intervention would be familiar with the fact that the emergence of drug-coated balloons have greatly improved patient outcomes, especially in femoral popliteal disease. However, there are a subset of patients who still go on to have a lesion restenosis. And we have seen from prior data that patients who undergo a repeat DCB treatment actually have a worse outcome compared to the first DCB treatment. So in other words, if a patient is very prone to have restenosis after DCB, then perhaps the initial treatment shouldn't be DCB in the first place. And you can see here how repeat DCB compared to de novo DCB use is associated with worse outcomes in both primary patency and CDTOR. And from a very nice study from Japan, they have looked at how DCB might fail after or within 6 months or after 6 months. And within 6 months, they define this as early DCB failure. Now, early restenosis is likely due to balloon failure rather than drug failure. So they looked at the factors associated with early restenosis and found 2 factors, one being it was a chronic total occlusion to start with, and the other being the involvement of an SFA osteal lesion. So later I have 2 cases that I would like to share that probably would illustrate these 2 factors. The first one being a 70-year-old man with claudication. He never smoked, but he was comorbid with hypertension, type 2 diabetes, and CAD. He has had claudication for years, but he initially thought this is normal. This is like part of getting old. But then he was referred to the cardiovascular clinic because the endocrinologist found his ABI to be 0.5 on both sides. The patient complained that the right leg was more uncomfortable, so we started the procedure focusing on the right leg first. And you can probably appreciate how there is an SFA total occlusion, but we weren't sure where the stump was. There has been some collateral vessels to the mid and distal SFA, a recanalized SFA at the mid part, and the below the knee artery seems relatively acceptable. If we looked closer, you can probably see there is a small haziness here, seems to be perhaps where the SFA ostium should be. And we did try to wire with a torqueable wire. This was Halberd 0.14. And you can see how, just to speed things up a bit, you can see how we managed to, wire into the plaque through some perhaps microchannels. But after some wiring, our wire was stuck in mid-SFA and could not advance, and so we shifted to retrograde. So the retrograde was punctured in the P3 segment, which I do not have the images here, but this was also an Astato 20 with a 6 CXI microcatheter, and we managed to meet the 2 wires with reverse cart and then subsequent balloon dilatation with a 5.0 and then by a 6 by 120 chocolate balloon. So this was the angiography after balloon angioplasty. And you can see how there is a very big dissection in the SFA ostium. Another thing that should be noted was that despite multiple angles, we could not get an angle that seems to separate the DFA and the SFA completely. So I was actually concerned whether there was some overlapping on the angiography of the DFA and the SFA. Otherwise, the mid portion of the SFA and the distal seems relatively acceptable, might probably not need a stent. So after some discussion with the patient, we decided to deploy a DES Illuvia in the SFA ostium. Now, the next question being how far into the CFA we can deploy the stent. Considering that I could not get a very good angiography that could separate the 2 vessels completely, and also because the DFA ostium seems relatively patent, I was more confident in covering the DFA ostium than missing the SFA ostium. So considering, and also there's a dissection flap that seems to extend all the way to the CFA. So we decided to make sure that we covered the entire dissection. So we deployed an Illuvia, I think this was 7 by 120, and then applied DCB, the Ranger DCB throughout the entire SFA to popliteal. And this was the final angiography of this patient. You can see how, I mean, after putting a stent, you would have a stent-like angiography. The mid portion of the SFA is not stent-like, but I think it's acceptable without significant dissection and good flow to the foot. The second case is a 65-year-old man also with claudication. He was a prior smoker, just quit smoking after smoking for more than 20 years. He also had hypertension, diabetes, dyslipidemia, and CAD, and it was significant claudication with limited walking distance to less than 300 meters. So this patient was not a stumpless SFA CTO, but you can see how there are multiple eccentric plaques, maybe calcific, from the CFA all the way into the SFA ostium. So it's really a mess here, distal CFA and bifurcation. The CTO segment is primarily in the mid to distal portion of the SFA, and just by fluoroscopy, you can see how although there is some trickle antegrade flow, it's probably not entirely a total occlusion, but it seems to be very calcified. And it just shows how although there are islands, we're not so confident that we can wire into these islands directly. So we did try antegrade wiring because it was not CTO in the proximal SFA, and we managed to get to this part where there is very dense calcification, after which we had to switch to retrograde, same with distal pop retrograde puncture. And you can see here how the CXI microcatheter was very deviated to the wall of the vessel. In fact, up to this point, if we look closely at the angiography, we would find that the islands inside the SFA were actually very eccentric. So the islands itself was eccentric, and if I tried not to wire into it, then I had to puncture the other way, and I would get subintimal on the other side. So it was very difficult to stay in the middle of the vessel. And you can see how when the two wires met, the wires were probably mostly in the subintimal space due to this heavy calcium. And in fact, this actually brought many problems because during balloon dilatation, we could see how this part was very difficult to dilate properly. And you can see how first we used a 5x300 balloon and followed by a chocolate balloon. And here there are still some wastes in the balloon. We did try to use high pressure conquest, but still it was very severe recoil noted. So, and finally we dilated with a CFA with a 7x80 balloon. So this was after balloon dilatation. You can see how the dilatation results of the CFA is suboptimal, and there is some severe recoil in the middle part of the SFA. So what next? In terms of stenting, should I stent the ostium or should I just stent the middle of the SFA, or should I stent both? And if I wanted to stent mid part of the SFA, should I use a covered stent or should I use a DES or should I use DCB with a bare metal stent? Now this patient was very active and very ambulatory, and I thought perhaps a cover stent was not the first choice in my mind, even though I do feel that this is a very difficult situation. And I thought, okay, because it is easy to follow up and he is very active, perhaps we should give a nitinol stent a first try. But then I asked the patient how many DESs he could afford, and he said he could only afford one. So whether I should put the DES in the mid-SFA or the ostium was another question that I had in mind. So I thought, okay, so the suboptimal balloon dilatation results in the CFA was probably due to the calcium. Also, I was very hesitant to put a stent in the CFA because I thought it was very messy and very calcific. I was not sure whether putting a stent right now in this relatively active patient would be the best choice. Perhaps any stent would reach the nose very easily. So we used a high pressure balloon up to 26 atmospheres. And you can see how after that the balloon, the CFA plaque seems to be better. And then we used a 7x80 DCB in the CFA to SFA ostium. So after which I decided to stent the mid part of the SFA with an illuvia. And this just shows how, so these two angiography are taken at different angles. And you can see how, although on the left-hand side, it seems to be not that bad a recoil, but if you took another angle, you can see how flat it is in this part. But anyway, we tried to deploy the stent normal to normal or relatively, and so we choose this part here, deployed an illuvia 6x120, and did post-dilatation. Now, I must admit, after the stent deployment and post-dilatation, I was pretty happy with the CFA, but was not so happy with the mid-SFA because I thought, okay, so maybe this radial force was not as good as I expected, but I probably couldn't do anything at that time anyway. And so 3 months after endovascular therapy, I brought the patient in for a duplex, and you can see this is the part distal to the stent. This is at distal SFA just above P1. You can see how it is a triphasic flow. And then we looked at the narrowest part in the middle of the illuvia, and you can see how it is still a triphasic flow. And if we looked at cross-sectional views, you can see at the part where it did not expand perfectly, but even at this segment, we could get a triphasic flow without a significant increase of PSV. So that was reassuring that although on angiography and on duplex, it didn't seem to be beautiful, but there probably was not much of a hemodynamic compromise. So to summarize, DCB and DESs improve outcomes in femoral popliteal disease. But even though we try to do DCB first try, but stenting is probably needed in selected lesions such as osteal lesions and CTO segments. And choosing a good device is important. If you want to use a good device, then choosing a good one is important. And regardless what you choose, doing a good work with the wiring, with the balloon dilatation still makes a difference. Thank you very much for your attention.
Thanks for Donna's excellent talk. And because it seems that Ida Sensei already online, right? Okay, so let me introduce the Ida Sensei. I think everyone here or even in Taiwan who majors in the peripheral artery disease knows the Ida Sensei. Ida Sensei is a very famous international peripheral interventionist. He already published many high-ranking papers in the literature, and he is also a very good friend like Dr. Soga, who came to Taiwan many times, and every time Ida Sensei came to Taiwan, he gave us a very useful and very impressive talk and let us know more about the PAD intervention innovation. So I think today Ida Sensei will give us a new talk that the title is the New Clinical Update of the Illuvia Stent. Ida Sensei, please. It seems that there is still some trouble. So now I think we will start panel discussion first. So Donna, because now you are the only one speaker, so you should receive many questions. So is there any question from?
Okay, is there any questions from the audience or from our panelists? Okay, Dr. Hong, please.
Oh, thank you, Ms. Lee. Okay. Hello. Okay. Okay. Thank you, Ms. Lin. Your fantastic talk about 2 cases. I have one question for your second case because from your presentation, you said that there's 2 risk factors for predict DCB fail. One is ostium of the L8 SFA, and the second is chronic total occlusion. But in your second case, actually, it's a very severe stenosis over the ostium of the SFA, and also the calcified plate was extended to the common femoral artery, something like that. So you just use the DCB alone, right? If the patient's recurrent, what's your plan?
I think the best choice for that patient was actually directional atherectomy and then with the DCB or DES in the ostium. I was very hesitant to put a stent there because the eccentric plaques were like in the CFA and then also in the SFA, and the DFA ostium was also very compromised. So I was not sure if I put in a stent, whether in the future I might need to re-intervene that part, what would happen at that time. Another thing is, so I actually thought maybe another choice would be, because of the economical issues, maybe another choice would be to put cover stent in the mid SFA, and then the patient can pay for the DS in the osteo SFA. But then I didn't really expect the recoil to be that significant in the mid SFA, because we actually did do balloon dilatation and the balloon expanded, so it was recoil. So I was actually a little surprised after I deployed the Eluvia. But then I think the Doppler was reassuring, because you can see still the triphasic flow within the stent. But of course, I mean, in the long run, say 2 years or 3 years down the track, I'm not sure what will happen, to be honest. Also, I think atherectomy would probably be needed in the CFA or the SFA. So I actually thought if in the future we have IVL, I would IVL both the SFA ostium and in-stent, because the in-stent probably needed some cracking of the calcium outside. But we don't have that right now.
Yeah, the cost is so high. Yeah. So yes, I agree with your plan, because if the recurrent happen, I think that some deparking device should be used. It's very necessary for this very high recurrent lesion. So I think that maybe next time atherectomy device, something like gesture, is that a good choice in this case?
I'm not sure about the CFA, because there is this, so his CFA is pretty big, and also because it's very eccentric, so I'm not sure if, I personally do not have experience, but I have seen Dr. Li Xingfu. He would perform, say, jet stream, and then external compression the femoral to make it have some type of wire bias, but I personally have never done that before, so I'm not sure. But he's very good at it, so I should ask him next time. But I think there are certain, you probably need to do some manipulation to make the lumen gain bigger. I'm not sure if jet stream is big enough in that part of the vessel.
Yeah, thank you.
Any other questions? About the second case. Okay. Yeah. There is.
Hi, good lecture. Yeah, I enjoyed it very much. I'm just interested that the second case, what is the cardiovascular surgeon in Xinguang? What do they think about the second case? Is there any better options for except endovascular treatment? Yeah, I would like to share this part. Yeah.
Yeah, I think that is a very good point, especially in the CFA. I think endarterectomy should also be a consideration. But so the patient himself is very reluctant to surgery. And also because cardiovascular surgeons in our hospital are very good at endovascular therapy, so maybe they will do endovascular too. But the patient himself is very reluctant, because his coronary arteries also, they actually had a discussion regarding bypass surgery for CABG at that time, and he also refused. So he is very reluctant to surgery. But I think this is a very good point. And also, just a reminder for myself, before the trial of BEST COI, as a cardiologist, I don't really look at patients' GSV status. But then after BEST COI, I actually, during Doppler for PAD, I would look at the status of the great saphenous vein. I think this is a very important reminder to cardiologists, because we are not that used to looking at the GSV conditions, to be honest.
For a great talking. You introduced the sirolimus DCB. I want to ask you, if the second case suffer from restenosis, would you try sirolimus DCB, or your previous experience? Have you some answer for this patient?
I think if the patient had a lesion failure event, I would probably have attributed it to the stent under expansion, which maybe does not have that much to do with the neo-intimal hyperplasia, but I'm not sure. And also the calcium. So at least from the Sirona trial, I think at least for 1 year, sirolimus and paclitaxel DCBs do not differ in the FEMPOP, but they seem to perform better in the BTK, which we don't really know yet. So if this patient comes again, I would ask him if he wants to go to bypass. If he still does not, then probably something needs to be done very aggressively in his mid-SFA to gain that lumen. And maybe I would try IVL or maybe just an oversized balloon, but I'm not sure if the oversized balloon can still have its efficacy within the stent and then perhaps cover stent or something. I'm not sure, to be honest.
Okay. Any other questions? Okay, Dr. Zhang, please.
So I think Donna has presented a very good presentation for the dry routine stent because you don't need to well lesion prepare, right? Yeah, because the calcified lesion is finally put the dry routine stent and they show us the final Doppler follow-up is good, yeah? So do you think the chocolate balloon is really needed for the patient because it's a heavy calcified? So I think even under the chocolate balloon, it still have some dissection over there. So that's my first question. Another question is because you show us the heavy calcified lesion and the osteo lesion both have the poor outcome of a drug-coated balloon, right? So I think from your two cases, you are afraid of the standing on the osteo lesion. Yeah, because you may be afraid of the CFA or other problems. So if under the chance, if the patient both have the osteo lesion and the heavy calcified lesion, so you always put the dry routine stent on well prepared lesion. Do you ever think about if this kind of a situation has a heavy calcified lesion, do you consider use the long DCB and the short bare metal stent? Do you think is any difference or not?
I really don't know. So I think calcified lesions are always very difficult, regardless of being the stent expansion or the drug efficacy. So I think I have always been very hesitant to osteostenting, mostly because of the deep femoral artery, because we do see that, you know, if the patient, I mean, it's a CTO lesion right now, and so there are collaterals in the distal, and I have preserved the collaterals. So I usually would preserve the collaterals. So if the patient really has a recurrent occlusion, then at least the DFA can save the leg. So this is why in terms of osteostenting, I choose nitinol stents over cover stents because it's easier. If I do protrude in the CFA a little bit, it doesn't seem to affect the DFA that much. So the question is how to well prepare the vessel. I think in the first case, the dissection actually came from the initial wiring, maybe not so much as the calcium because of the angle. So I tried not to wire into the DFA, and then there was this trickle flow, and I think perhaps that route was already very deviated to the one side of the vessel. So the dissection maybe came from the wiring instead of the balloon dilatation. But previously with stumpless SFA occlusions, every time we try to prevent wiring into the DFA, we would deviate very far to the lateral side, and often that is where we get the dissection. So I think indeed this is very difficult. I tried to use something with a direction like the JR guiding catheter to point the JR to where I think the ostium is, but still it's very hard to point to where I should be wiring in the middle of the vessel. I think perhaps maybe EVAS at this time would have some role, maybe. I'm not sure. I don't have any experience in EVAS though. Oh, chocolate balloon. So Yeah, the chocolate balloon was primarily for the ostium. I don't think it's going to work in subintimal space. So, I mean, I knew I wired through the subintimal space in the mid-SFA, which the chocolate balloon probably doesn't work or doesn't do anything. I was trying to preserve the ostium when I asked the patient to pay for the chocolate.
At here, I need to tell everyone, especially for Donna, bad news that is Dr. Ida is now still busy on the table. So I think we still need to keep our panel discussion. But I think we can a little bit shorten, so maybe around 2 to 3 questions. Yeah, for Dr. Dong.
Can I ask a question?
Oh, of course. You can ask questions. We have a lot of panelists.
Yeah. So I've always had this question regarding how to know specifically where the SFA transits into popliteal, because we know how it goes through the hiatus, and we don't want to, stent that further down into, say, P1 or P2. But that is a really angle thing. It's like I look at it from this side and that side of the angiography. Sometimes I'm not very certain. And how do you know how distally you can deploy the illuvia? Is there a safe marker that I can refer to, or is it just a feel? Oh, I think this is still in the SFA. Maybe not that much in the pop, or
maybe I can. In my personal experiences, I will say that I don't concern that too much if somehow I think from the distal SFA to the proximal popliteal, I think it's okay, and somehow they would be the most sharing. I mean the most common disease site that we have to face. So, and if there is some calcification or critical lesion layer, somehow at that point we need a scaffold. So I don't concern that too much. But actually, I won't put the stents over the P2 area because maybe they will be, we have to more concerned about that. Okay, so I don't know if there's any other comments from the panelists.
Sorry, from Thailand. Same idea with you. We did not concern about the stenting in the more proximal of the popliteal artery. I just want to share that there is a small series from Stephen Kuhn from Singapore that he stent illuvia stent across the joint. For the midterm result is quite okay. There is no stent fracture, but of course we don't want to stent across the joint. But in case you cannot deploy the supra stent and you have to deploy the illuvia stent, I think for the acute outcome, midterm result is quite okay. The second point that I would like to share with you that when you cannot find the ostium of the SFA, maybe if you go near true lateral, you can see the separate the angle of the SFA and profunda, or maybe you can use the external ultrasound to identify. Somehow the flash occlusion of the ostium of the SFA, I did the cannulation under the external ultrasound. Maybe it's more easy by under flu. Yeah, thank you.
My opinion is similar to previous speakers. And is there any other opinion from our panelists about the issue Dr. Donna mentioned?
Actually, I totally agree Dr. Wu's comment. There's no concern to stand into the popliteal artery because we need to treat the lesion precisely, or optimization. Is that any terms of optimization in peripheral artery stenting, I don't know. But in coronary, that's called stent optimization, right? So you need to treat the disease fully. So, but based on your question, if you're concerned about your stent will maybe some risk of stent fracture, you can do the knee bending test. So the patient was supine and you just bending her knee, you can see that where is the vessel, the tortuous side, where is the tortuous side of the popliteal artery began. So you just marking the landing, so you can avoid the stent maybe into the bending zoom of the popliteal artery. Maybe you can try it. Somehow we always do that in our cath lab.
Finally, let me ask the final question: is how to treat the Eluvia stent in stent restenosis (ISR)? Because should we use a different kind of DCB like the sirolimus or even other different DCB, or just still we can use a paclitaxel DCB? Is there any currently any evidence about this field? And for the ISR or even total occlusion, is there any difference?
I think it depends on what time the occlusion occurred. I have had, unfortunately, friends from Boston, please ignore me. I have had a case which had a occlusion very early after Eluvia stenting, but I think that was because I did not achieve a good enough outflow from POP to the foot. So in that case, I wouldn't think it's the problem with the paclitaxel or the stent. But if this occurs, say maybe between 6 months to 12 months, then maybe the patient is just very, we have seen patients who are just very, how should I put it, very, the disease is very aggressive after stenting. Like ISR just occurs very quickly, or at least after say 6 months to, between the 6 months to 12 month window. And in these patients, I usually go for a covered stent. But then the covered stent, you need to have a good proximal and distal preparation because sometimes the landing zones are a concern. And also the covered stent is sometimes would sacrifice where the collaterals come in. So there are multiple concerns. I think the outflow is very important. So we had this discussion last night regarding in claudicants, do we need to do the tibial arteries for their disease? I think if to improve the outflow for the FEMPOP, sometimes treating the tibial arteries is necessary. That is to maintain a good outflow, to prevent the hard work that you did in the FEMPOP occluding very early.
Okay. Now time is limited, and we have very, very good discussions in this Lunch Symposium, and thanks Dr. Lin to hold on the whole session. I'm glad that we gathered together here and have received so much informative lectures involved, including the Eluvia stance, the strategy, the tip and tricks, and the excellent cases that give us so much information and have so much discussion. So actually, I also want to remind all the entity from Taiwan domestic maybe interventionalists that currently our national health insurance have the standing procedure, the procedure fee have some changes. So maybe I think now we have so dedicated stands here, and we might have the chance to give the individualized procedure to let our patients have the best outcomes in the futures. So, I want to do the final closing remarks here, and thanks all the attendee, here, and we are following the today's
Thanks
seminar.
for everyone's attention. Yeah, we will close this lunch symposium. Thank you.